Good morning. Let me start by thanking you, Kathy, for your leadership of the committee to re-examine the IOM weight guidelines on which I had the privilege of serving, as well as now for your leadership of the committee on implementation of those guidelines. Now, most of you are aware that Kathy was the recipient of the prestigious Agnes Higgins Award from APHA last year. Now, many of us who serve on the committee with you jumped at the chance of nominating you for that award, really in recognition not only of her extraordinary contribution to the science and practice of M.P.H nutrition, but also for her extraordinary leadership that over the past 5 years that have really brought us to where we are today. So I just want to take a moment on behalf of HRSA and the Maternal and Child Health Bureau to thank you, and please join me in giving her a round of applause. I also want to just take a moment to acknowledge the staff of the IOM, and especially Anne. Where are you, Anne? And the Board of Children, Youth and Families, and the Food and Nutrition Board, and also just the members of both committees for their extraordinary leadership on this very important work. Now, I was asked to kick off this meeting by talking about its significance, and I thought I would do that by providing a historical context of what's led up to today's workshop. Now, I'm not going to talk much about the 1990 guidelines because I was still in medical school when those first set of guidelines came out. But in 2007, the IOM convened a committee to re-examine pregnancy weight guidelines, which I had the privilege of serving on along with some pretty amazing colleagues. The question is, why re-examine these guidelines? And the answer is because that was then, and this is now. Okay. So back in the 1990s, when the IOM released its first set of guidelines, the primary concern was about preventing low birth weight. Okay. But now we have an obesity epidemic that's going on in our country, and pregnancy weight gain may be a major driver of that growing epidemic among women of childbearing age. Now, American women have been getting heavier for a long time, but particularly so since 1990. In the last 20 years, the proportion of women of childbearing age who are overweight or obese have nearly doubled. Today, more than half are overweight, and about 1/3 are obese. And if you just look at pre-pregnancy weight, we see similar trends. More American women are entering pregnancy overweight or obese. And what's more, the proportion of women who gain too much weight during pregnancy has also increased since 1990. Today, 1 in 5 American women gain more than 40 pounds during pregnancy, with the largest increasing among non-Hispanic white women. And this trend is particularly troubling among women who are overweight or obese. Today, nearly 2/3 of women who are overweight and nearly half of women who are obese gain more than what's recommended during pregnancy. Now, this slide is a little complicated, but it makes one simple point. The more weight you gain during pregnancy, the more weight you retain postpartum. Now, this is true for whether we're talking about postpartum weight retention of 10 pounds or 20 pounds of more than 6 months postpartum. It's true for women of all race, ethnicity, and pre-pregnancy BMI. The more weight you gain, the more weight you retain. I want you to pay close attention to this slide here. Number one, for women who gain above IOM guidelines, they never get back to their pre-pregnancy weight. Okay, again, for women who gain above IOM guidelines, they never get back to their pre-pregnancy weight. Now, second, for overweight and obese women, gaining at or below IOM guidelines help them maintain a postpartum weight that's at or below their pre-pregnancy weight. So let me summarize. More U.S. women are entering pregnancy overweight or obese. More U.S. women are gaining too much weight during pregnancy. And the more weight women gain during pregnancy, the more weight they retain in the postpartum. And both the gestational weight gain as well as postpartum weight retention are major drivers of the obesity epidemic among women of childbearing age. So our committee also looked at the consequences of gestational weight gain for both the mother as well as the child. For the mother, we found strong association between higher gestational weight gain and increased risk of cesarean delivery, and strong association between higher gestational weight gain and postpartum weight retention. For the child, we found strong association between gestational weight gain and birth weight, such that lower gestational weight gain predict SGA, small for gestational age, and higher gestational weight gain predict LGA, or large for gestational age. We also found weaker evidence for association between gestational weight gain and preterm birth, that lower gestational weight gain was associated with preterm birth among underweight and, to a lesser extent, normal weight women. Another child outcome we were particularly interested in was childhood obesity. And we found that higher gestational weight gain was associated with childhood obesity in 4 studies that were identified by the AHRQ review, and our committee identified 3 additional studies supporting that association. All but one study reported child BMI as the only outcome, but in the one study, there was high systolic blood pressure in 3-year-olds that was found to be associated with higher gestational weight gain, suggesting possible developmental programming effect of gestational weight gain. So again, to summarize, lower gestational weight gain associated with SGA and possibly preterm birth. Higher gestational weight gain is associated with cesarean delivery, postpartum weight retention, LGA, and childhood obesity. And so clearly there's a trade-off that has to be made. And really that's how we'd approach making the recommendations for the new guidelines. There's the old guideline, and note that for obese women, there was no upper limit. It just said to gain at least 15 pounds. Now we examined a number of analyses that looked at these trade-offs, actually including one that actually recommended weight loss for class 3 obese women. We commissioned Dr. Eleanor to rerun her analyses for us, and what we found was that as small for gestational age, that small for gestation age goes down as gestational weight gain goes up. But you can see that for overweight and obese women, that the absolute risk gets flatter, gets smaller for overweight and obese women in terms of the small for gestational age. Postpartum weight retention, in contrast, goes up with gestational weight gain, and that was true for women of all pre-pregnancy BMI categories. So you can eyeball where these lines cross and see that they do change with pre-pregnancy BMI, such that they really cross at a lower gestational weight gain for overweight and obese women. We commissioned additional analysis to inform our recommendations, including one that considered infant mortality, postpartum weight retention, child obesity, and used qualities for comparisons across outcomes. And all of these led to these new guidelines, which look remarkably similar to the old guidelines with 2 major exceptions. First, we use that the new guidelines use the WHO BMI categories, so women no longer just magically change their BMI categories when they become pregnant. And second, for obese women, instead of recommending at least 15-pound weight gain with no upper limit, we recommended a range of 11 to 20 pounds. Now, the caveat here is that the range really came from data for women with a BMI of 30 to 35. Data were insufficient to create recommendations specific for heavier classes of obese women, where further research may actually suggest that lower gain might be desirable. Now, just to complete summarizing our recommendations, we made no modifications for short stature, young age, racial ethnic subgroups, primary parity, as well as smokers. And we made some provisional recommendations on the rate of weight gain, as well as twin pregnancies based on limited data. So what next? So it followed from our analysis that there are two things that we must do. First, we must help women gain within the guidelines. And second, we must help women achieve healthy weight before pregnancy and get back to a healthier weight after pregnancy. So first, gain within the guidelines. Now, we knew that these guidelines were not going to be easy to follow. We know that about 1 in 5 pregnant women gain more than 40 pounds during pregnancy. And using PRAMS data, we found that overweight and obese women gain on average about 10 pounds higher, 10 pounds more than the midpoint of their recommended range, and that more than half and probably closer to 2/3 of overweight and obese women gain more than the upper limit of their recommended range. So getting them to gain within the IOM guidelines is going to be a major challenge. We thought that it would be a great disservice to women if we set these guidelines that most of them cannot meet without providing additional support. And that's really where the second committee came in. And I really want to come in and congratulate the work of this committee so far, starting with this logic model, which reminds us that it's going to take really a lot more than just setting guidelines to effect the behavioral change that we want to see, which again is to help women gain within the guidelines. So I know Kathy's probably going to spend some time going over this model or something similar to this model, so I won't say much now, but this model maps out the steps that it takes to help women gain within the guidelines. Healthcare team learns the guidelines, healthcare teams teaches women, women learn the guidelines, women choose to gain within guidelines, taking into context the family and friends, eating environment, social cultural environment, as well as advertising. So the question that each of us should ask ourselves today is, where do we see ourselves in this logic model? If we believe this is the right thing to do, if we really want to help women gain within the guidelines, where do we see our roles and what difference can each of us make? Now, later on today, you'll hear from experts. We're going to talk to you all about communicating these guidelines, supporting behavioral change, and implementing these guidelines. And again, I want to thank IOM for bringing this all together today for this very important workshop. We come from different backgrounds, different disciplines, different expertise. We come across disciplines, across sectors, across silos, e pluribus unum, out of many, one. I think this is going to this is what it takes to make this happen. That this is going to be what it takes to turn the tide against this growing obesity epidemic. Now, although we're going to talk primarily about helping women gain within guidelines, I do hope that we will take some time today during the workshop to address the second point about helping women achieving healthier weight before, between, and beyond pregnancy. As mentioned in our report, the guidelines themselves are not all that different, but what it will take for women to gain within them represent a radical change in the care of women of childbearing age. Again, not only during pregnancy, but before pregnancy, between pregnancy, and beyond pregnancy. So let me talk a little bit about what we're doing at the federal level, and then I'll turn it over to my partner in crime, who will talk about what's going on in the private world. Since 2005, CDC and HRSA, along with other partners, have has led this movement to improve preconception health and healthcare in the United States. The Office of Minority Health have also launched a campaign to promote women's preconception health through peer education in predominantly communities of color. CMS, the Center for Medicare and Medicaid Services, recently convened an expert panel on interconception care, and USDA, the Food and Nutrition Services, have kind of launched a project on the role of WIC in improving paraconceptional nutrition. But I think the game changer this time is really going to be the Affordable Care Act. The ACA took a giant step in putting the W back in M.P.H. It put an end to the discriminatory practice of gender rating, charging women higher premium because of their gender. It also prohibits the practice of denying coverage for pre-existing conditions such as breast cancer or C-section, and lifetime caps on benefits, which will expand access for millions of women with chronic conditions. And through Medicaid expansion and subsidies for women who lack employer-sponsored health insurance, the ACA expands access to healthcare coverage for nearly 19 million previously uninsured women. And beginning August of last year, with implementation of the clinical preventive services for women, an additional 47 million women will gain access to preventive health services, including coverage for gestational diabetes, intimate partner violence, HIV screening counseling, STI counseling, HPV DNA testing, FDA-approved contraceptive products, breastfeeding support, as well as woman visit, including preconception and interconception care, which provides an extraordinary opportunity to improve women's health, not only during pregnancy, but again, before pregnancy, between pregnancy, beyond pregnancy, and indeed across their life course. The ACA is probably the most important women's health law in the past 50 years, so we got to figure out how do we make most of the opportunities afforded by the Affordable Care Act to improve women's health and helping women gain, achieve a healthy weight before, between, beyond pregnancy. So let me just conclude with a few of my favorite quotes. If you want 1 year of prosperity, grow grain. If you want 10 years of prosperity, grow trees. If you want 100 years of prosperity, grow people. To which I would just add, if you want to grow healthy people, you start by growing healthy babies. The definition of insanity is doing the same thing over and over and expecting different results. We must become the change we want to see. And then this last one. For those of you who can't see in the back, it says never ever think outside the box. Now that may be true if you're a cap, but if we really want to do something about helping women gain within the guidelines and helping them achieve a healthier weight before, between, and beyond pregnancy and indeed across their life course, we really got to start thinking outside the box. Thank you very much.